Good afternoon, everyone present here. I am Faraz from IJCP. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Ash Sujit Ji sir. Sir has done MBBS, Diplomate of National Board of Obstetric and Gynecology, and Fellowship in Minimal Access Surgery, World Association of Laparoscopic Surgeon, WALS, Diploma in Gynecological Endoscopy, Kiel University, Germany, IRCAD, France, Senior Consultant in Gynecology and Obstetric Department of PD, Hinduja Hospital, Mumbai. Today, sir is going to discuss on a topic obstetric high risk in India. Let me tell you overview of the topic. Obstetric high risk refer to a condition during pregnancy that puts the mother and of the fetus at an increased risk of complication. In India, obstetric high risk is a major concern due to the several factors including poor maternal health, inadequate access to healthcare, and cultural factor that can delay seeking medical attention. The high prevalence of anemia and malnutrition in the Indian women also contributes to increased high risk during pregnancy. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you, Faraz. Thank you for the introduction. Good afternoon, everyone. Today, I'll be discussing high-risk obstetrics in India, and we'll see what all challenges that we have to deal with in the next few slides. So, when it comes to India, high-risk pregnancy in general, when we think about the concept, is one that affects the mother or the newborn or both of them and leads to health complications. And this can arise anytime during, before, or even after pregnancy. When you think about a high risk pregnancy, it doesn't necessarily mean that the pregnancy will be more difficult or challenging when you have to compare it with a low risk pregnancy. But what this means in general is that the doctor, like us, and the neonatologist, the physician, the anesthetist would be more involved in certain situations that we'll be seeing over the coming few slides so as to make the pregnancy and the outcome better. When you see in India, nearly around 20 to 30% gestational women go through high risk pregnancy. Yet, there is a little understanding of the management and prevention of high risk pregnancies per se. According to WHO, as per the reports, there are 830 women die daily as a result of complications during antenatal period and childbirth. 830 daily. That's a huge number when you take into statistics. And the five main reasons that we all must have read or heard or seen are hemorrhage, which is because of anemia also, and the complications of PPH, maternal infections, which can happen because of poor hygiene or because of any operative interference which is not healed properly. Unsafe abortions, around 15.4 million abortions happen in India every year. So when you think about that, unsafe abortions or illegal abortions are still on a rise, even though we have MTP laws, which are the best when you compare it to any other Western countries also. Hypertension related disorders, what we easily known as preeclampsia or eclampsia, this also leads to a lot of deaths. And any medical complications such as cardiac conditions or HIV or AIDS or diabetes complicating or complicated by pregnancy, these factors also contribute to a higher level of maternal morbidity and mortality and therefore becomes a high risk for obstetricians. There are various parameters that you have to think about whenever you're discussing India and high risk obstetrics in general. The most important thing that we come across is socio-demographic status. You think about, like, I practice in Bombay, you're the affluent society, so you think at least the issues which are there are easily identified or are identified at an earlier scenario as compared to the women who stay in the rural areas or who are not from a very good socio-demographic background. They either ignore or they don't have doctors to reach out to. Therefore, in a country like India, where there's a lot of socio-demographic difference, this becomes a very important factor. Ethnicity, yes. We live in a country which has a lot of cultures and ethnicity throughout. Like when you compare north to south, west to east, everywhere is different. So their social practices are different. So this affects the diet, the immunity status, or maybe some medical scenarios like thalassemias or sickle cell anemia. This differs from ethnicity also. So therefore, this becomes an important factor. Place of residence, where the patient is staying, where the mother stays, how far it is from the urban health center or the local health center or from the hospital, how the facilities are to reach the hospital. These factors have to come into the thought or consideration whenever you're thinking about this scenario. Education, so that the woman, the husband, they can understand the risk of the situations involved. Whatever discussions we have, that has to be implicated or explained to the patient and the relative or the accompanied relative in a way that they understand it easily and they accept whatever management that you're going to offer to them. Occupation, again, certain health related disease can be affected with the lifestyle and the work that they are doing. Therefore, it becomes important. A proper history taking will always include your occupation also. Place of antenatal care, wherever you're thinking about a PHC or a UHC or a tertiary care hospital, where the care is offered, how good the facilities are when you think about whether you have an NICU setup, whether you have a blood bank, whether you have ambulance service, or whether you have a proper NICU, ICU for the mother. These parameters again come into important when you think about the place of antenatal care and number of antenatal visits. How many times the mother has to visit a doctor regarding her entire ANC. In general, what we have is the first visit which happens, then a visit at around 12 weeks with the NT scan, then a 5-month visit with the anomaly scan, and 2 scans with the growth visit, that is the visit. So at least 5 visits have to happen. Depending upon whether there is a high risk status which is involved, the frequency of visits will be changing, and that has to be customized as per the patient. When you consider the obstetric risks which are involved, you have to think about these are the broader classification that have enlisted for you. So maternal age, lifestyle, underlying health conditions, and obstetric risk. In maternal age, young or old maternal age, whether it's a teenager or an elderly woman, they have different issues that are challenging for us. So, as a teenager, she might have anemia, she might have malnutrition. The entire pelvis is not very ready for a delivery, so she can have a preterm delivery. Normal delivery might become difficult, so there might be more chances of getting obstructed and operative interference or even cesarean. When you think about an elderly woman, you have to think about that this is something which is a norm at our places. So we explain them that the risk of diabetes or blood pressure in pregnancy goes higher. So risk of preeclampsia and GDM is definitely higher. Apart from that, women above 35, above 40, they can land up with pregnancies which have a higher risk of chromosomal issues. As we know that Down syndrome at 40 years, the risk is 1 in every 250. At 45, the risk is 1 in every 40. So these statistics, you have to tell the patient, you have to explain the patient beforehand, before you start the thought of conception or preconception with them, so that that continues and that is reflected on the way you manage the patient. The other thing is lifestyle, smoking, alcohol. These are some things which are very common, which have to be curbed, which have to be curtailed before a patient even plans to have a baby. Overweight and obesity also are something which is seen very commonly. We discussed about malnutrition, which includes not just low weight for the mother, but even overweight. Obesity in general increases the risk of blood pressure, preeclampsia, gestational diabetes, also increases the risk of neural tube defects or stillbirths and difficult delivery, which can land up with cesarean delivery. And in general, this woman will also have higher chances of getting infection, sepsis. So therefore, it's a cycle which will continue. Again, as per the thesis, which is the hypothesis, you will have a baby who will also have something like this in the genes. So the baby might also land up with obesity in the laterhood, in the later adulthood. So therefore, this runs in the family. Therefore, you have to correct it. Other existing health conditions such as blood pressure, diabetes, HIV positive, or I recently had a patient who had a kidney issue which flared up because of the pregnancy. Yes, you have to tackle all these things side by side as you're managing the pregnancy. From the obstetric viewpoint, you have to think about multiple scenarios. I have enlisted two that multiple births when you have a twins or triplets, then it becomes a complication for the doctor to think about all the aspects. The maternal aspects, yes, you have to think about anemia or whether you have to think about her general condition because of the grossly stretched uterus, or you have to think about the mode of delivery for her. For the twins, then you have to think about whether it's monochorionic, dichorionic, and the associated complications which can happen there. Placenta previa, this is something which is very dreadful for any obstetrician. The complete placenta previa can lead to massive bleeding. She might present with spotting or bleeding throughout the entire pregnancy also. Therefore, this becomes a high risk for doctors who have to think about managing such high risk women. Then coming to the mode of delivery, then mode of delivery, vaginal is something which is preferred, but you should know which patients should be delivered vaginally, which will require instrumental and which will require cesarean. If you have a CPD, if you have a large baby and you're delivering the patient, like the patient is a primary gravida, then obviously the chance of vaginal delivery becomes big difficult. Or if you are expecting shoulder dystocia, you have to be ready for it. If you have a GDM mother, she'll have a baby who has broader shoulders, so therefore the chances of shoulder dystocia increases. Therefore, these are the scenarios where you have to be over prepared and anticipate rather than just managing it immediately like a chaos. Maternal complication that can happen during a post delivery, which include postpartum hemorrhage, peripartum hysterectomy because of certain issues that were there, supposedly a placenta crita or uncontrollable bleeding, which happens in all the parameters leading to puerperal sepsis because of malnutrition, because of too many procedures done can lead to that. Placenta increta, rectus sheath hematoma, which can happen with a cesarean which is not controlled properly, or you're not checking the rectus sheath bleeding, or urinary complications which can happen. UTIs are usually masked in pregnancy, and the subclinical UTIs can lead to preterm deliveries, and then you forget about it, and then this can expand more and can lead to a lot of other complications. Frequent PV per vaginal examinations also give rise to a lot of local infections that can happen. So these few parameters have to be taken into concern. Apart from that, mean blood loss needs to be assessed. You have a minimal bleeding of around 500, which is acceptable in a vaginal delivery, around 1000 in a cesarean. So that's a criteria that you should remember. Check on the mob count, check for the blood loss which happens, and if there's a need for blood transfusion, keep it ready, keep it handy. Know the blood group which is available in your blood bank or from where you should make it available in case of emergency, and eventually the duration of stay. So you have to keep in mind the financial condition of the patient also, how many days the stay would be required. Post a normal delivery, probably 2 or 3 days. Post a cesarean, maybe 3 or 4 days. So that depends on how good your the recovery of the patient happens and whether the baby has any complications. That way you decide on the duration of hospital stay. So the complication that in general that we can come across is a preterm delivery, preeclampsia or GDM, birth defects that can happen because of nutritional deficiency or age, operative interference in deliveries, hemorrhage, anemia, infections, and eventually the financial burden that can happen on the patient. And all these will lead to a poor mental health, postpartum depression, and that is something we should not forget as doctors, which can affect the patient. When it comes to neonatal complications, we check for the birth weight again. So, malnourished, poor outcomes, the baby will be low birth weight. If the baby mother has GDM, then there are chances that the baby will have an overweight, and that would be large for dead babies. So this is something which will calculate, and the neonatologist will keep a track of this. Apgar scoring must. Every delivery should have an Apgar at birth, 1 minute which is happening, then after 5 minutes, after 10 minutes. So that is the charting that has to be kept. And then NICU doctors should be charting it and making a note of it, because sometimes immediately after delivery the Apgar is good, but after 5 minutes or 10 minutes, suddenly there is cyanosis because of certain cardiac issues, or because of GDM, the sugars go down, and then the baby will have hypoglycemia and start showing certain symptoms. So this should not be missed. Admission in the NICU can happen for a multiple reasons. So that can be because of prematurity, because of birth asphyxia, if because of obesity and because of high birth, the heavy weight women, they might have lowered postdatism. Postdatism might be there, which can be also associated with meconium stain liquor and meconium aspiration syndrome. Babies can have early onset neonatal sepsis, also congenital pneumonia, transient tachypnea, newborn, congenital anomalies, and birth traumas because of operative interference and neonatal hypoglycemia. This is something in general which can be experienced whenever you're trying to manage a high risk pregnancy in that situation. And that will also decide the duration of days the baby will be staying in the NICU, which will vary depending upon the complication that you're trying to tackle. And eventually that will affect the perinatal outcome. So if there is anything which is not managed well, and that can lead to some lung issues or cardiac issues, or more importantly, what we're worried about is the HIE, the hypoxemic encephalopathy, or something like a sepsis which affects the colon and the intestine, and that will lead to a major complication which can happen. So all these things, the perinatal outcome becomes important during then. So how do you approach this? Whenever you have to think about obstetric high risk, the important thing, whenever I say, is that prevention is better than cure. So if you have a patient who is planning for a pregnancy, start with that level. Preconception counseling always becomes important before or when you have to manage a complicated pregnancy. Give a proper preconception advice, get all the necessary investigations which are required at a basic level. I also ask for the rubella and varicella antibodies, because if by any chance infections like these happen in pregnancy, then the babies have a high chance of having any complication like cataract or deafness or cardiac issues, limb issues. So it's better to get an antenatal preconception checking for the varicella rubella, give them the vaccination, and then let them proceed. You check for the liver profile, basic kidney profile, check for the sugars, the thyroid. These are basic tests that we ask during pregnancy also, but it's always better to find it out before pregnancy, that you can treat them or manage them before the patient starts a conception. Apart from that, non-invasive things when the patient comes into you with pregnancy, NIPT is something which I started doing it off late for women above 35. NIPT is non-invasive testing that you do. This will test the mother's when from the mother's blood, the blood is taken, and this will check for the fetal DNA circulating in the mother's blood, and that can be used for karyotyping or finding out genetic abnormalities. Initially, in the initial days, we used to do chorionic villus sampling, the invasive test like the amniocentesis or the cortocentesis. But nowadays, we have something so beautiful, something so good like the NIPT. Little on the expensive side, but worth it. You're not doing any damage to the baby. And plus, this is something which will give the result in the same time as compared to the CVS or amniocentesis or cortocentesis. Apart from that, your dedicated fetal ultrasound, which has to happen at particular weeks, and you should know what you need to check out for. Supposedly, you're doing an NT scan. Yes, you'll be checking for the NT, the nuchal translucency, but also check for the nasal bone, because that is also a soft tissue marker for Down syndrome. Check for the cervical length in such scenarios. You might check everything and the baby is fine, the liquor is good and placenta is good, but you've forgotten to check for the cervical length, and the patient might land up with cervical insufficiency later on in the second trimester. So check for the cervical length in the NT scan. Then after that, go into the anomaly scan. In the anomaly scan, again check the detailed, read the reports, check for the thing, because sometimes we tend to just look at the impression, but we miss out on little things which are written in the detailed thing. So check on that. And I usually have a tendency of asking for Dopplers also, along with the investigations, along with the sonography. So, diastolic notch, which is seen at the NT scan, that can be a predictive marker for preeclampsia. Yeah, so you can start with your aspirin at that point. At 24 weeks, you can get the fetal 2D echo, which happens, and then you can check for any sorry, you can check for any cardiac issues that can happen for the baby. Apart from that, 28 weeks and 36 weeks also you can ask for the Doppler, so that you can check for the neutroplacental and the umbilical placental insufficiency if there are any chances for that. In particular scenarios like Rh negative or anemia, so these parameters become very important, and even in PIH, because this is one of the markers which show that how good or bad your blood pressure is being controlled. Apart from that, always start with the prenatals, which are important. The folic acid has to be started as soon as you're thinking about any pregnancy. You start with your iron and calcium medication, do proper investigations at regular intervals so as to find out whether the patient is thalassemic or not thalassemic before you're loading the patient with iron or IV iron. NST, CTG, I guess everyone knows about the non-stress test or the cardiotopogram. This can start anywhere after during the third trimester. At 32 weeks, even 28 weeks have been documented that you can do the NST, and you should know how to read an NST. Maybe someday we'll do a class on the NST, but then NST, the baseline, the variability, the acceleration, deceleration, the contraction, the fetal movement, the mother pressing for the fetal movement. With NST, you can actually identify around 10 to 12 conditions which can be noted, which will help you to predict or at least stall a complication which can happen. Nowadays, there are possibility of embryoscopy and fetoscopy, which have been done by the fetal expert doctors, and that also can be used. And you can perform surgeries in utero for the fetus so as to avoid any complications for the fetus once the baby is born. How to prevent? I guess I just finished the entire last slide with all these things. Preconceptional counseling, which becomes important. Discuss medical risk. What are you expecting for the mother to have any complication during the pregnancy, like blood pressure, diabetes? Yes, we've spoken it to at large, but then whatever it's done, it's always less because we are seeing a lot of cases of GDM and PIH in pregnancy. So that is why it has to be spoken about. If there are any particular other risk like epilepsy, then you have to know which medication should be allowed, which medication should be stopped. If there's any cardiac issue, then you know which medications are safe in pregnancy and which will not affect the baby. If there's any renal complication, then you need to check for the output. You need to put the medication on some diuretic, but that should not affect the liquor formation. So these little things, depending upon organ specific, you should think about it, discuss with the physician, plan it out. It's not just the obstetrician taking a call or just the physician taking a call. It has to be a multidisciplinary approach. Even the neonatologist or the pediatrician has to be involved in these things so that they also are in the loop whenever things are going ahead. Healthy lifestyle becomes very important. If smoking, alcohol, those things have to be curbed on. Coffee is something which always people think that is blamed for, but I usually allow my patients 2 mugs of coffee, which is okay. That much is fine. Alcohol, again, there are a lot of debates about alcohol, but then one odd while having an alcohol depend upon the patient entire profile. You can think about it. Diet, balanced regular diet has to be done. So I do one thing, which is after 12 weeks, I tell all my patients to go and meet a dietitian so that a particular diet is recommended for her, and she'll be in touch with that dietitian throughout the entire pregnancy. I'm usually not fond of advising protein powders because nowadays they have a lot of sugar also, and it's per se it's something which you're having it, which is extra. Have change in your diet, have a proper balanced diet, that itself will work out. I do a dental checkup which happens again at 12 weeks because then you forget about the dental infection and dental caries, and that will stay throughout the pregnancy because the mother won't get time to refer to that later. So again, a dietitian and a dental advice which happens at 12 weeks for me. The vaccination, I do an influenza vaccination which happens at 12 weeks. The changeover of vitamins where I add the iron and calcium at 12 weeks, and the tetanus vaccination which happen at 28 and 32 weeks respectively. At 32 weeks, I also do a breast examination for the patient so that if there's any nipple which is inverted or if there is some issue which has to be picked up, that is picked up before the patient starts breastfeeding. That's something which you all can add it to your practice also. Surgeries, if anything is needed during the preconception or any surgeries which are required during the pregnancy, I had a talk recently where I spoke about the surgeries which are required in pregnancy. So yes, we can go ahead with it if it is life threatening for the mother or the baby. So if you have a gallbladder issue or if you have an appendix issue, they can be tackled. They have to be tackled as per the latest ACOG and the American Association of Anesthesia guidelines. Any surgery, if it's required for the mother, then you go ahead with it rather than waiting on it and then leading to any complication which will affect the mother and the baby. Most importantly, you should know and have a referral system. So we have our tertiary hospitals which has everything which is there with us. We know that the ICU, if there's anything which is there, we have doctors on call around 24/7. We have a physician, an intensivist, a surgeon which is there. But as doctors who are practicing outside in the peripheries or in the outskirts or at a urban health center, you should know that where you have to be referring in case of basic emergency obstetric care or a specialist comprehensive emergency obstetric care, which is there at your call basis. So if you have to shift the patient, you have to think about these parameters also, where you should know the skills of the referring staff, the tools of diagnosis, the institution and the availability, whatever you are looking out for, and the quality of care that will be offered. Along with that, again, think about the cost of care, the distance and the transportation and the communication, which is important from the patient and the family point of view, not just as a doctor's point of view. Yet this type should have your proper NICU and the blood bank and everything, which will determine that where you need to send which patient for the high risk. Government of India also has started something interesting, which is called as the PMSMA, Pradhan Mantri Surakshit Matritva Abhiyan. So something which is there as a scheme which reduces the risk of high risk pregnancies and to provide quality antenatal care for pregnant women throughout the country. So this is available throughout in India. And as doctors and as healthcare providers, we should be frequently monitoring whatever is there as the scheme which is available so as to reduce the trend of high risk pregnancies and increase the favorable maternal and neonatal outcome. That is the least that we can do as healthcare providers so as to improve the quality of service delivery and strengthen the interventions that are already in place at various places. So, in conclusion, complications can or will and might occur during pregnancy that can affect the mother and the fetus. But it is important to assess and screen for high risk complications so as to reduce maternal and perinatal morbidity and mortality. And such complications can be minimized with early intervention by a specialized gynecologist and extra prenatal care. Thank you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, I can see that we have received some question from the participant end. If you allow, can I take this question with all your
Sure,
permission?
sure. Let's start. Let's start with the
Okay,
question.
sir. I can see the first question is that how do you explain the risk of to your patient when you inform them about the prenatal screening test?
So the antenatal, prenatal kind of screening test is something which I have started in my hospital itself. So this is something whenever a patient comes to you at whatever age, there is something which I ask them to do. So one is the rubella and the varicella antibodies. Be it a teenager or anyone who will be ever getting pregnant, you have to protect them against these infections. So that's one thing. Whenever you're planning for a prenatal test, ask for a CBC. I'll just give you the list of whatever investigations I ask. Ask for a CBC. In that, you'll obviously check for the hemoglobin. If you find that the hemoglobin is less, ask him for a thalassemia testing, the HB electrophoresis. Check for the WBCs and platelets. That's one thing. Check for the urine to rule out urine infections. Apart from that, check for the sugars, fasting blood sugar, postprandial if at all possible, but even fasting is fine, and HbA1c. That becomes very important. That will show you a 3 month control. Thyroid and prolactin. Thyroid subclinical hypothyroidism is something which you're all aware about. That is something you'll be checking out for. Prolactin, yes, irregular cycles or something like that can happen. So you check for the prolactin. Prolactin itself will lead to subfertility. So that's one more testing which is done. Basic liver profile. I don't ask for the entire thing. SGOT, SGPT is something which I ask for. In the kidney thing, you ask for the BUN, creat, and you ask for the uric acid also. Lipid profile, if in case there's a deranged lipid profile, which is there you start managing because obesity and complication we all aware about. And vitamin B12 and vitamin D testing is done so that vitamin D is also known to lead to subfertility, so you test for that. And a sonography which will show me a 3D sonography, preferably if possible. That will show me the entire cavity properly to find out if there's any polyp or any fibroid, any ovarian issue. So once you have these things sorted, then depending upon the age group. So if you have a woman who's elderly, get an ECG done. If there's any back issue, get an X-ray of the back done. So these are basic things, and apart from that, specialized thing which you ask for. Explain to the patient that once this is there, we'll treat if there is something which is required. If not, this will form a baseline, and we'll be repeating this investigation throughout in the pregnancy at different intervals so that we have something to compare. Always tell them that we have something to compare so that we are not just blindly treating you or managing you when you're pregnant. So then when they understand these points, and then when you tell them that we'll treat only if it's required, then they'll understand it better, and that is how you will be proceeding with the prenatal counseling and the investigations.
Okay, thank you so much, sir, for explaining it really well. I hope that participant has received his answer. Moving forward, I can see another question from Dr. Meghna, and she's asking what is the treatment of acute leukemia during pregnancy after 12th week if a mother decides to save her fetus?
So you have to explain the mother and the entire family that there will be complications which can occur with the treatment of acute leukemia. If you're managing any cancer, yes, cancer in pregnancy will be detrimental because whatever anti-cancer or whatever things that you will be giving the mother will affect the fast-growing cells of the baby. The fast growing cells of the baby, 12th week to 28 weeks is when your organogenesis will start happening. If any drug that you'll be using, that will or most definitely will affect the fetus, and that can lead to long term complications. Talk to the oncosurgeon or oncologist that which medications you will be using. Most, whatever, as per as my knowledge, whatever I'm aware about, most drugs will pass through the placenta barrier and will affect the fetus, so it will become a high risk. Ideal thing or the best thing would be have a group discussion with the physician. Yes, always involve a physician whenever you have a complicated case. An oncologist, the gynecologist sit together, involve a pediatrician if possible, because the pediatrician has to also explain the later on outcomes, which can be because of the resultant drugs that you'll be using, and give them the options and take a consent, proper consent, that so and so, if the mother has asked that I want to continue the pregnancy, tell her these things are there, write it down in a paper. You have to be safe, so write it down in the paper, tell her that these complications have been explained, yet the pregnancy has been decided to be continued by the mother. In the words they understand the best, take the signature of the mother, the parent, and the doctor, and everything has to be documented. If she moves in for an agreement that yes, we'll be continuing, not continuing, then that's a different issue. But again, just a second, sorry. But again, that also will become important, that you'll be checking on for those things, that acute leukemia will affect your other parameters, including it can lead to some other blood parameters like DIC or other complications, because the immunity will go for a toss. So these things have to be taken into concern even if you're planning for a termination. Challenging case, but again, multidisciplinary approach will help you succeed it out and give better outcome to the patient.
Okay, thank you so much, sir. I hope that Dr. Meghna has received his answer. We can see, sir, there are a couple of questions. We will be taking last two questions for today's session, sir. And Dr. Sadhana is asking, in pregnant women with a history of recurrent miscarriage, can progesterone supplement help them to carry to term?
So, recurrent miscarriages, you have to find out what's the cause. That is one thing which I didn't take in this, because that's a huge lecture in itself. Recurrent miscarriages, what's the cause of recurrent miscarriage? Whether it's something which is related to antiphospholipid antibody syndrome, that is APLA syndrome, or something which is leading to because of thrombophilias. You think about that, or you have to think about whether there is some structural anomaly in the uterus. So, if you're trying to manage it out, every scenario has to be controlled differently. So just recurrent abortions, giving a progesterone, that's the thing which I've seen. I recently had a patient who was given vaginal progesterone, who was given oral progesterone, who was given injections of HCG, who was given some other projects. She was given a lot of medication, and the progesterone also has its side effect. The woman will have mood issues, she'll have bloating, breast tenderness. So you have to think about that. First, find out what's the reason for the recurrent abortions. Most of the times you have to just give aspirin or heparin. That's the management when you have thrombophilias or apla syndrome, and then you give progesterone as a standby. If you have something in the uterus, whatever you do, if there's a huge fibroid which is leading to the complication, your recurrent abortions won't be sorted. Progesterone, there's a tendency that we give progesterone empirically, even in the books, even as per guidelines. Progesterone is empirical treatment which can be given. Yes, I give it too, because eventually for me that patient matters. But think about one way of giving progesterone, continue that rather than overloading that woman with progesterone. And as per the dictum, progesterone has to be started somewhere around as early. If you have some issues, you start it early at the time of conception, and you have to give it till 32 weeks. You're welcome to stop it if you think that the progesterone is not required, and stop it. But till 32 weeks is the guideline, as per the guideline, that you continue till 32 weeks, and then you can go ahead. So, moral of the story: find out the cause of our recurrent pregnancy losses, investigate the woman properly, think about what is the cause, and then think about the definitive management rather than giving just empirical progesterone.
Okay, thank you so much, sir, for explaining it really well, sir. And moving forward, we will be taking last question for today's session from Dr. Manoj Agarwal, and he's asking, what is the most accepted regimen of Mg sulfate used in the preeclamptic woman after delivery?
The one which we have, the Pritchard regimen, that is one thing which is followed everywhere. I have here currently moved to the Zuspan thing, where you have the injectable IV thing, because the class of patients I deal with, they usually don't prefer giving butt injections. The gluteal injections as per the norm. So I move on to Zuspan. So Zuspan or Pritchard, whatever you like, you can continue. The Sibai, Alasolanki, whatever regimens you're following, eventually the outcome matters. You have to be able to reduce the risk of convulsions that happen, and you have to control your blood pressure. Apart from that, whatever method you're taking, it's okay. Understand the risk of magnesium toxicity. Check in those for those parameters also. Keep your calcium gluconate in case of any toxicity of magnesium. These things are important. Regimen wise, Pritchard, Zuspan, whatever you like, you follow it. That you are welcome to go ahead with whatever you like. Thank you.
Thank you so much, sir, for answering all the questions, sir. I hope that the doubts of all the participants has been clear. I can say there is one feedback from Dr. Ayushi Singh. She has written very well covered, and thanks for this presentation, Dr. Ash,
Thank you,
sir.
Dr. Ayushi.
Yeah,
Thank you,
I
Dr.
hope
Ayushi.
that yeah, all the participants have really learned lots of things about this topic, sir. As there is no more questions, sir, shall we conclude this session with all your permission?
Definitely. Thank you. Thank you
Yeah,
so much
thank
for
you so
having me.
much, sir, and hope to see you again with different topics, sir. Till then, take care of
Okay.
yourself, sir. Have a great
Thank
day
you,
ahead.
sir. Goodbye. Goodbye, everyone. Bye bye.
Bye, sir.